बट सीमा अभी ज्वाइनिंग कम ही हुई है, 2-4 मिनट का टाइम दे दो।
ओके सर, फिर विल
है ना, 2-4 मिनट करवा रहा हूँ ज्वाइनिंग बोला
हाँ
है।
जी हाँ जी।
और एक रिक्वेस्ट थी डॉक्टर शिफाली, आप अपनी स्लाइड शेयर करें, स्क्रीन शेयर ना करें, क्योंकि उससे क्या हो रहा है कि टेलीस्कोपिक स्क्रीन्स विजिबल।
मैम विजिबल है?
आपकी स्लाइड्स आती है, पर अभी जब आप स्क्रीन देख रहे हो ना तो
ये ठीक है,
ये ठीक है मैम?
ये ठीक है।
ओके ओके, थैंक यू।
गुड आफ्टरनून रूबी मैम। Good afternoon, everyone who has joined.
Good afternoon, everyone. Dr. Seema, good afternoon.
Good afternoon, ma'am. Sir, 20 participants. Okay, shall we start? Sir? So we are going to start. Good afternoon, everyone. On behalf of Satluj Academy of Pediatric State IIP Chapter of Punjab 2026, we are here welcome Dr. Shifali Gupta, DM Medical Genetics, currently working as a senior consultant at Pragma Institute, Bathinda. And I also welcome Dr. Monika Sharma, Professor and HOD CMC Ludhiana, and Central IIP EB member from State of Punjab. I welcome both of you on World's Down Syndrome Day. The theme for this year is Together Against the Loneliness. So I request our President, Dr. Gurshan Singh Narang, So share his words and formally start the meeting. Over to you, sir. Sir, are you there?
Dr. Seema, yes, I am driving presently. You can continue.
Okay. So I request Dr. Monika Sharma to say a few words on the World's Down Syndrome Day. Dr. Monika Sharma.
Thank you, Dr. Seema. I think it's great that you are organizing this online session. And it's nice that SAPA is organizing a lot of academic events, which are going to be a great learning opportunity. It's wonderful to have a geneticist talk about Down syndrome, and I'm hoping I'll get to learn something new. Welcome, Dr. Shifali.
Thank you,
Thank you,
ma'am.
ma'am.
Dr. Mandeep, sir. Dr. Mandeep, sir, Treasurer, SAPA 2026. Okay. Okay. Over to Dr. Shifali Gupta. Please start your presentation. Dr. Shifali, please start your presentation.
Audible and visible? Hello?
Yeah, you are
Okay.
audible and visible, but your video is stopped. It's okay. You can keep your video on and start moving.
Okay,
It's
um,
yeah.
the video is also on, ma'am. From my side, it's on only.
Yeah, video is on. Yeah.
Okay, ma'am.
Okay.
So, good afternoon, everyone. So, at the outset, I would like to thank Satluj Academy of Pediatrics, Dr. Seema ma'am, Dr. Gusharan sir, Mandeep sir, and Dr. Monika ma'am to give me an opportunity to speak on this vital topic, that is Down syndrome, that too on this great day, which is International Down Syndrome Day 2026. So, today I'll be speaking about Down syndrome, and I have tried to make it interesting as well as simple, especially from the resident's perspective. So, the learning objectives for today's talk would be an overview of Down syndrome, genetics and correlation to the clinical phenotypes, what are the common clinical features and major organs involved, surveillance and screening of a child with Down syndrome. What is Down syndrome? As we all know, it is trisomy 21. That is, the long arm of chromosome 21 is extra and it leads to the phenotype. And Down syndrome is characterized mainly by mental retardation, characteristic facial appearance, multiple malformation, especially congenital heart diseases, and a small but significant risk of acute leukemias. And it is due to an extra copy of long arm of chromosome 21. It was first derived by Dr. Langdon Down in 1866, from where it gets its name, Down syndrome. So the incidence of Down syndrome is around 1 in 700 to 1000 live births, which means almost all of us have seen many cases in our lives leading to Down syndrome. And if we talk about the genetics, trisomy 21 is overall the most common trisomy found in humans, and also it is the commonest chromosomal disorder. However, the frequency is variable among different population due to change in the average maternal age of the pregnancy. And here I would like to say that as chromosome 21 is the smallest chromosome, so extra copy of this chromosome is well tolerated, leading to Down syndrome. Whereas other chromosomes, if they are present in excess or an extra copy, they can lead to severe consequences like death.
Dr. Shifali, you are not audible. Dr. Shifali? Dr. Shifali, I think her internet connection has gone.
Static. What she can do is she can stop her video.
Okay,
That
then
her
then
voice
only.
and
Okay,
Yes,
I will
ma'am.
call her.
yeah,
Yeah,
you
stop
stop
the
the
video
video.
I
and
have
yeah.
done, ma'am.
Yeah.
Is it audible now?
Now again start.
Ma'am, is it audible now?
Yes, yes.
It is audible.
Okay.
Yes.
Okay. So, as I told, that chromosome
But your
21.
slides are not visible. Only the telescopic slides are visible.
Now, ma'am, please.
Now also
You
not
can
visible.
stop sharing and then share your PPT again.
Okay, ma'am.
And do not audio switch on your video. Only just
Mhm.
PPT. Good.
मैम दिख रहा है?
अभी दिख रहा था, हाँ अब दिख रहा है अभी दिख yeah, good,
Shall I
good.
start now?
Yeah, please start.
Okay. So chromosome 21 is the smallest chromosome, due to which
Volume again went, it's
no.
gone away. You're not audible.
Hello?
हाँ अब audible है.
ठीक है. So the life expectancy has increased from 25 years in 1983 to 1997, and currently it is 50 to 55 years. So talking about the genetics of Down syndrome, it is due to three main mechanisms. First is that we all usually talk about, that is free trisomy, which means that whole chromosome 21 is present in an extra copy in this patient. And 95% of the cases are due to this free trisomy of chromosome 21. And this extra chromosome is maternal in origin in 88% of the cases, and around 12% of the cases it is paternal in origin. And the frequency increases with increasing maternal age, that we all know. And another subset is due to Robertsonian translocation. 3 to 4% of cases are due to this Robertsonian translocation, and they are not related to maternal or paternal age. And I'll come to them in my next slides. Another subset is trisomy 21 mosaicism. Now, what do we mean by mosaicism? Usually in a case which is not mosaic, whichever cell we test in the body, like hair, from the skin, or from the blood, all the cells, they will show us an extra copy of chromosome 21, which is normal. Okay, but if some of the cells they have trisomy 21, some of the cells they have normal chromosome complement, these cases are known as mosaic. And due to this mosaicism, the phenotype may vary. To mosaicism. So the first type that I told is free trisomy. So free trisomy, why does it happen? It happens due to non-disjunction. Like we can see, suppose this is an oogonium. During meiosis 1, all the chromosomes, they have to align in the center, and the spindles lead to their spindles pull them into equal halves. However, if due to any reason the extra copy of one chromosome, it goes into one half. For example, here we have two copies of this chromosome and no chromosomal copy in this polar body. Now this secondary oocyte, when it will fuse with a normal male gamete, it will lead to trisomy of this particular chromosome, which can be chromosome 21 also. So this is the reason of free trisomy, that is non-disjunction. Second is the translocation type. In translocation type, suppose there are two acrocentric chromosomes. Acrocentric means one long arm and one very short arm, and the centromere is towards the end. Suppose there are two acrocentric chromosomes which are non-homologous. Non-homologous means this is chromosome 14, this is chromosome 21.
Dr. Shifali, please connect to some good network. Your voice just goes away in between and then it restarts on its own. Can you please change your network?
Hello, ma'am.
Yes, now you are very nicely audible. Yeah.
Okay.
Just repeat this translocation. Yeah.
ठीक है ma'am. So
Non-disjunction.
one type was non-disjunction leading to free trisomy. Second type is the translocation type. So suppose we have two acrocentric chromosomes. Acrocentric means there is one short arm, one long arm, and centromere is in between. we have usually, in our karyotype, we have 4 acrocentric chromosomes. Suppose these 2 acrocentric chromosomes, which are non-homologous. Non-homologous means this is 21 and this is 14, some other chromosome, not the other 21. Okay. So if there is a break in these 2 chromosomes and the break leads to rejoining, which is long arm of both joined together and short arm of both joined together. This is called as Robertsonian translocation. But in this person, in this particular person, the total genome remains the same. It's just that they have broken and rejoined at some other place. And these people, they are usually asymptomatic and they are known as Robertsonian translocation carriers. However, okay, this is another photograph to show the same thing. Suppose there is a 14th chromosome, chromosome 21. And the Robertsonian translocation will lead to this part of 14th will remain normal. This 21 will also remain normal, whereas these two, they will break and join. And this is the new chromosome 1421, in which has long arm of both 21 as well as 14. And this person will remain normal. And this will be, this person, when gives rise to an offspring, this will become the parent of a Down syndrome child. So in these carriers, the total chromosome number when we do a karyotype, it comes out to be 45. It's not 46, which is the normal usual complement. And the child with Down syndrome will have only 46 chromosome because the extra copy is attached over it. So these are the second type of babies with Down syndrome. And this picture, it shows how the chromosomes segregate while gametogenesis and leads to the various type of Down syndrome babies. Like here is the translocation Down syndrome because we have 3 long arms of chromosome 21. So coming to what are the risk factors for getting a baby with Down syndrome, they include advanced maternal age, and it rises exponentially after the age of 35 years. Second risk factor is any previous child with Down syndrome or other chromosomal abnormality, then also the risk of having Down syndrome baby increases for future. Third is if parent has Robertsonian translocation and they are carrier for this translocation, then also the chances of having a Down syndrome baby increases. Another thing is about the maternal age. We all know that as the maternal age advances, the risk of having a baby with Down syndrome increases, and these are the incidences given. However, if we wish to remember, roughly we can think that in 15 to 30 year age group, the risk is 1 in 1550, and after that we'll keep on doing half. That is, in 30 to 34 year age group, the risk becomes roughly half, that is 1 in 800. 35 to 39 becomes roughly half, 1 in 270. 40 to 44, 1 in 100, and 45 and above is 1 in 50. So we all know that Down syndrome is most common in mothers with age group of more than 35 years, that we all know. However, 80% of the Down syndrome babies are born to the mothers who are less than 35 years. So why is it so? Because of the fertility rate. More and more pregnancies, they happen less than 35 years of age. That is why more and more Down syndrome babies, that we see in the clinical practice, mothers are not of that higher an age. So this is the reason, because the fertility rate is more below 35 years of age. Now coming to the clinical features in Down syndrome. So 21st chromosome, it is having 46 million base pairs and many genes. And it is due to these genes which are extra, there are many phenotypes. For example, there is a Down syndrome critical region, which if present in 3 copies, leads to Down syndrome. And the research is going on to knock down this particular region so that the phenotype of Down syndrome or the complications, they get attenuated. Similarly, there are genes of deafness, leukemia, myeloproliferative disorders, TMDs, Alzheimer's disease, etc. So broadly talking about clinical features, we get to see flat faces, poor Moro's reflex in a newborn, hypotonia, hyperflexibility of large joint, slanting palpebral fissures, loose skin on the back of the neck, pelvis will be dysmorphic on radiographs, small round ears, hypoplasia of small fingers and the middle phalanx of small finger, and finger palmar crease. For example, in this child, If we look at the picture, what are the indicators that tell us that, okay, we all know this is a Down phenotype, but how do we describe it? So she has mongoloid slant. If we look at her, this is upslanting palpebral fissure, mongoloid slant. Second is hypertelorism or depressed nasal plus depressed nasal bridge. Nasal bridge is depressed. Hypertelorism means both the eyeballs, they are are far away. Another thing is she has clinodactyly. And then this is a simian crease. So these are some gross pointers in the gestalt that give us an impression that, okay, this baby can be Down syndrome. In addition to these babies, they have apicanthal folds, they have flat occiput, brachycephaly, and lymphedema and low set ears, hypotonias. That leads to our suspicion that, okay, this could be a Down syndrome baby. Then coming to the hand and feet. In hand and feet, there can be simian crease. Simian crease is single transverse palmar crease, and it is seen in 40 to 50% of cases with Down syndrome. There can be Sydney crease also, which is the proximal transverse palmar crease that reaches the ulnar side of the palm. And it can be seen in many other things also, like rubella embryopathy in addition to Down syndrome. Then palmoplantar hyperkeratosis, sandal gap and Kennedy crease, brachydactyly, clinodactyly. I'll come to them in the pictures. So if we look at the normal hand, these are the normal palmar creases. Okay, if there is a single transverse palmar crease, then it is called as simian crease. However, at times, many people, they have a confusion that is this a simian crease or not. So this is not a simian crease. When there are two creases and the proximal one is transverse, it is called as Sydney crease, not the simian crease. And Sydney crease is not very specific for Down syndrome. It can be seen in other cases also. And what about if simian crease is present in a normal individual? Yes, it can be present, and it is present in 1 to 2% of normal population as well. Apart from that, this is the sandal gap, and this deep crease in the sole is called as Kennedy crease. Then coming to a little word about dermatoglyphics. So on and off, we see in our clinical books that 80° angle, it gets increased in Down syndrome babies. So what is that 80° angle? I'll just take. So this is so in the hand, we have many dermatoglyphics, right? These are the whorls, these are the loops, these are the arches. And wherever these three patterns meet, that is known as a triradius. Okay, so there are many triradii in our hand, and some of them are like I have marked in this picture at the proximal digits. They are A, B, C, D, and a triradii on thenar band is T. Normally, this ATD angle is acute. Okay, this ATD angle is acute in a normal hand. However, if this ATD angle, it becomes obtuse, that means we are having a brachydactylic hand. The hand has brachydactyly, meaning short hand. This is the objective criteria to say that it is a brachydactyly. So this ATD angle increases in cases of Down syndrome. Next, coming to the growth. So birth weight, length, head circumference, they are less in Down syndrome babies at birth only. Plus, they have a reduced growth rate. And over the period of time, they become obese by 3 to 4 years of age. And prevalence of increased birth weight in adolescence is way higher than the normal children. So this is a chart showing some milestones. These are quite delayed in case of Down syndrome babies. Then coming to the systemic involvement. So grossly, if we talk about systemic involvement, in neurodevelopmental domains, there are intellectual disabilities, developmental delays, language disorders, cerebellar hypoplasias, anxiety, depression, behavioral disturbances later in the life, Alzheimer's and epilepsy. And cardiovascular, we all know that AV canal defects, congenital heart diseases are very common. In musculoskeletal, there can be short stature, short fingers, hypotonia, and very important thing that should always be monitored in these kids is atlantoaxial instability. Apart from that, in craniofacial, that I have already described, and then there can be sensory and conductive hearing losses. In ophthalmic examination, there can be refractive errors, cataracts, keratoconus, etc. They can have obstructive sleep apneas, respiratory tract infections, and there can be autoimmune problems like thyroid disease, celiac disease, alopecias, type 1 diabetes, psoriasis, etc. Plus, these babies, they usually have infertility later in life. So, as already told, in CNS, there can be cognitive disabilities and epilepsy, and a global developmental delay in infancies. And average IQ ranges 25 to 50. 6% of them can have seizures. Other very important CNS manifestations that should be kept in mind is cerebellar and vermis hypoplasia, moya disease, Alzheimer's, and behavioral issues. So, any Down syndrome baby presenting with hemiplegia, acute onset hemiplegia, and seizures. One should always keep in mind moya disease leading to the stroke. Another important clinical feature is intellectual disability, which is almost always universal, and it starts in the first year of life, and it varies from profound retardation to near normal IQ as well. However, their social IQs are better than their overall IQs. So we should also know here that Down syndrome is the most common known genetic cause of most moderate to severe intellectual disability. Then Alzheimer disease, as we discussed, due to extra gene, the protein formed is more and leads to Alzheimer disease early in the life. Almost all the patients older than 40 years of age, they get Alzheimer's because of amyloid precursor protein, which is formed from the extra 21 chromosome. So in cardiovascular, around 44% of the babies, they have congenital heart disease and they require ongoing surveillance for this. And an echo is mandatory at birth. And so these are the spectrum of disorders that can be present in cardiac. In GI, 5% of the babies can have GI anomaly in the form of duodenal atresia or stenosis, annulopancreas, imperforate anus, and tracheoesophageal fistulas. Hirschsprung disease is also very common, and celiac disease, which is an autoimmune disorder as well, it is also common in babies with Down syndrome. In ophthalmology, there can be phenotypic features like epicanthal fold, brush field spots, and cataracts. And later on, there can be refractory errors, strabismus, nystagmus, and keratoconus. So this also needs regular surveillance. Endocrinologically, there can be thyroid disorders in 30% of the babies, and they can also have diabetes type 1 or type 2 and should be regularly screened for the same. In fertility wise, females, they have normal genitalia and rare cases of fertility are reported in the females. However, males, they are almost always infertile with undescended testes and hypogonadism.
Oh.
So in hematology, there can be transient myeloproliferative disorder in 20% of the newborn. Plus, later on, there are risks of hematological malignancies like AML, M7, ALL, etc. And another thing, very important thing is atlantoaxial instability. I'll take a minute to explain what is it and how it should be screened and prevented. So normally, we all know that in our cervical spine, the first vertebra is known as atlas and the second is known as axis. And it is this dens of the axis around which atlas moves. Okay. So the spinal cord, it passes from here, this place. So normally when the head moves forward, atlas also moves forward, but all the ligaments around this, they prevent excessive movement and the spinal cord passing through here, it remains normal. However, due to joint laxity in Down syndrome babies, this atlas, while flexion, it moves in excessive anteriorly. This leads to compression of this spinal cord passing through here, and this compression is known as atlantoaxial instability. And how do we objectively measure it? It is the anterior surface of the dens and the posterior surface of tubercle of C1. We see the distance between these two, and this distance, if increases, there are different guidelines, but usually it is less than 3 mm. And if it is more than 4.5 or 4, we consider that it could be AAI, and we take an neurosurgery opinion, plus we offer a CT scan. So if the distance increases, it will lead to the displacement, compression of the spinal cord. So this I have explained. So how do we diagnose this atlantoaxial instability? Is the neck films. They are taken in flexed, neutral and extended position, and we have to see the first and second cervical vertebra. And joint instability is labeled if the space between two, it is more than 4.5 mm. So for example, in this picture, here it is this C1, this is C2. We have to look at this distance between these two. And if this distance, it increases more than 4.5, then it is called as AAI. So once we have diagnosed or clinically suspected that, okay, this baby has Down syndrome, what workup do we need to do? And how to confirm that, okay, yes, this is Down syndrome? And then what organ screening is required, that once Down syndrome is diagnosed, what all organs need to be screened. Third thing is what long-term surveillance is needed in these babies. I'll come to them. So confirmation, as we all know, is via karyotype, which is the gold standard. It tells us about how many total chromosomes are there, and here the extra copy of chromosome 21 is there. However, karyotype is little time taking. It takes 10 to 12 days because fresh sample is needed, culture is needed. At times, it may fail also, and repeat sample may be required. So in such scenarios where the diagnosis is very urgent, for example, in malignancy cases, or the baby is about to die, we need to know something like that, we can go for rapid tests like FISH and QF-PCR. The results, they usually come within 48 to 72 hours. For example, in this FISH, we can see there are 3 signals in place of 2. So it confirms. Similarly, in QF-PCR also, based on these peaks, we diagnose that, okay, there are 3 copies of 21. So this was about diagnosis. Now coming how to screen and follow up the kids. So screening and management is as per the various guidelines. So there are various guidelines by American Academy of Pediatrics, some European guidelines, as well as some Indian guidelines from Indian Academy of Pediatrics. So usually that is followed is in a Down syndrome baby. At birth, we have to do a karyotype. Then we have to do a CBC also, and then subjectively thereafter, whatever is the result, we have to look later on the follow-ups also. Then cardiac evaluation, baseline at the time of birth, and if any problem, then follow up accordingly. If it is normal, then follow up in the adulthood. And the other 3 things, that is thyroid, ophthal, and hearing, they require more frequent surveillance. For example, thyroid evaluation is to be done 6 monthly for 1 year, and annually thereafter till the age of 5 years or 18 years. Different guidelines, they say differently, and we have to follow them up 6 monthly if the TPO comes out to be positive. Second is ophthalmological assessment. It should be screened by 6 months of age, and then annually we have to screen. Hearing assessment, again screening at birth, as in routine babies also we are doing, and annually thereafter. Another thing is cervical spine. In general, we see that many times we tend to order that, okay, get a neck x-ray. So it is not to be done routinely. It is to be done only if there are clinical features of cord compression. So this was a clinical practice guideline by Indian Academy of Pediatrics. And this is also in consensus with what I have previously mentioned, that is karyotype and echo at birth, thyroid function test almost 6 monthly for 1 year, and then annually, and then it can be continued SOS. Similarly, CBC and PBF are to be done at birth and then annually till 5 years of age. Hearing evaluation annually till 5 years of age, and then it can be done every 2 years. And ophthal evaluation is also after 2 years, after 5 years of age. So additionally, there are special charts for growth monitoring of babies with Down syndrome given by CDC, and their growth should be plotted in these charts only. And there are also some papers about growth charts for weight and height of Indian children with Down syndrome. They are based on around 1200 patient data. However, more extrapolation is needed for using them into clinical practice. Then coming to the management. So for routine immunizations, there are no restrictions. In fact, these parents should be counseled about additional vaccines uh, apart from national immunization schedule, and influenza vaccine should be always emphasized. Then ask for GER, any features of celiac disease or sleep apneas in each visit. Early stimulation therapy, physiotherapy, occupational therapy, speech therapy should be told. Vocational therapy, hygiene and self-care needs to be given. Then behavioral issues need to be addressed, plus genetic counseling should be offered for future pregnancies. Now, many a times patients they come to us in genetic clinic to ask about the sports restriction. So there are various recommendations for screening prior to participation in the sports. For example, this was a 12-year-old boy who wanted to participate in the sports. So for them, we had this discussion. So for these babies, we have to do just a clinical examination, and if a clinical examination is normal, there are no signs of cord compression, they can be told to participate in the sports easily. So, the same thing that I told, that in a baby with Down syndrome, if there is any warning sign like neck pain, abnormal head posture, torticollis, reduced neck movements, deterioration of the gait and frequent falls, increasing fatigability on walking, deterioration of manipulative skills. So, if any of these signs is not present, then routine radiological screening should not be done, and the child should not be barred from routine sports activity. They can be allowed special sports if detailed examination is not suggestive of cord compression. However, if any of these is present, then we have to take a good history examination. In history, they usually say okay, the child used to be very active earlier, but now he's always sitting, and they tend to correlate it with the increasing weight, that due to weight, as weight has increased, the child is always sitting. However, it is actually due to the cord compression at times, because at around puberty they tend to gain weight also. Then we have to take good x-rays as well as referrals from the respective units. So what are the sports that are you considered to put the patients with Down syndrome at higher risk of developing atlantoaxial instability? These are gymnastics, trampolining, diving, and butterfly stroke in diving, pentathlons, contact sports like martial arts, rugby, high jump, etc. And we, if someone asks, we can tell them to avoid these sports. Now, a word about anesthesia in these babies. So, routine X-rays are not recommended prior to anesthesia because they give false sense of security. It's just that care should be taken not to hyperextend the neck while intubating. In general, also when we are intubating, we should take care that okay, the AAI can get precipitated, so we should avoid hyperextension. And careful history examination is the key, and for any warning signs. Now, what about the counseling? How to counsel these families? So, genetic counseling is done when the child comes to the clinic for the first visit regarding need for testing. Sorry. So, detailed counseling is done after confirmation by karyotyping or FISH or QFPCR. We have to discuss the wide range of variability in manifestation and prognosis. Medical educational treatments intervention should be offered to the family. Initial referrals for early intervention should be done. They should be attached to certain whatever groups are available in that area. Very important is we have to talk about positives. We should not shade over the negatives. Usually, when the patient comes, our general tendency is to say, okay, this is a Down syndrome baby, isko chhod do, iska kuch nahi hoga. So that should be avoided. We should always be very careful while telling them, gradually disclose the things. And we should also discuss regarding the reoccurrence risk for next pregnancies and preconceptional counseling and workup. So here I would like to show about the reoccurrence risk. For example, if the karyotype of the previous baby, it has a free trisomy 21, then the recurrence risk is 1%, which means 1 in 100. That is in 100 pregnant. 1 in 100 means more than 1 in 250. So upfront amniocentesis or CVS is indicated. And if it is a translocation type of Down syndrome, we should look for karyotype of the parents. If the parents are a carrier of that translocation and the carrier is mother, then the recurrence risk is as high as 15%. However, if the father is a carrier, recurrence risk is 5%. And if one of the parent is carrier of translocation 2121, then the recurrence risk becomes 100%, and we have to tell them about alternative options of pregnancy. So what all they can do once the family comes to know that okay, they are conceiving another child. So serum markers, ultrasound, NIPT is available, followed by definitive testing like CVS or amnio, and genetic testing. So invasive testing, this I'll skip. So what if the Down syndrome is detected? So newest MTP Act, it allows abortion till 24 weeks, but we should not push for abortion. We should just inform them about the phenotype, about the complication, and the decision should be of the family itself. Plus, if the parent is carrier of 2121 translocation with 100% recurrence rate, we should give them other options like IVF or by donor gametes or by adoption. So, is it all bad? So the prognosis is not that bad nowadays. Life expectancy has increased, as I told. Most likely cause of death in these babies is congenital heart disease, and later on dementia, hypothyroidism, and leukemias. Survival has improved because of increased placement of infants in various special schools and homes and change in treatment also. Survival is better for males and for the blacks. So now I'll come to an interesting case. Related to Down syndrome only. So this was Miss S, 12-year-old girl, resident of Jalandhar, Punjab. She was a known case of Down syndrome and she had a difficulty in walking and getting up from past 1 month. She had neck pain for 1 month also. And at birth, she was diagnosed. Her mother's age was 23 years at the time of delivery, home delivery. And they came to know about the Down syndrome status at around 2 years of age during a routine vaccination follow up. So she started having weakness and difficulty walking and getting up from lying down position associated with neck pain radiating to the limbs and neck movement restrictions. However, there was no history of trauma or any history suggestive of autoimmune joint pains. So there was antenatal, as I told, was normal. Family history, she was born of a non-consanguineous marriage. There were two elder siblings. They were all fine, immunized for age, and she attained menarche at 11 years of age, and the cycles were regular. And developmentally, she was delayed. However, at 12 years of age, she was studying in class 6, and as per parents, she had a satisfactory school performance. They were not worried about Down syndrome thing. They were like okay with it, and actually they were not aware that how bad is Down syndrome, so they were happy kind of parents. On examination, there was characteristic facial gestalt and with upslanting palpebral fissure, epicanthal fold, brachydactyly, depressed nasal bridge, sandal gap, etc. And on systemic examination in CNS, she had E4, V5, M6, hypertonia, power was 5 by 5, brisk DTRs, planters were extensor with a normal sensory and cranial nerve examination. Rest of the systemic examination was non-contributory. So this clear cut leads us to a differential of atlantoaxial instability. So where when we did an X-ray, it was suggestive of increased predentate space, and CT confirmed the diagnosis of AAI. The posterior C1 C2 fixation was done and collar was applied for 6 weeks, and followed by that she was asymptomatic. There was no pain, no weakness. She could do her routine activities, and this was the video after around 6 weeks that they had sent that she was doing all fine. So this was to just to emphasize that appropriate care can lead to a good outcome, and suspicion should be kept. So there are various support groups in India as well. Down Syndrome Support Group and Down Syndrome Federation of India. We can connect the parents to these support groups. And this was another child who went to Paralympics recently and is under follow up at PGI. And this is another example, Aditi, 23-year-old girl who owns her own cafe, and she's in India only. And they can grow old too. So these are few glimpses of the celebration of this great day at PGI last year. So my take-home messages are trisomy 21, meaning 3rd March 21. So affection of almost all the systems and intellectual disabilities universal. They need screening and follow-up from birth only. Prenatal diagnosis can be offered to the families. Overall outcome is not that bad, and parental counseling and support is of utmost important. And 21st March, I think it came from extra 21 chromosome, which is in 3 copies. So 3/21, March 21. That is World Down Syndrome Day. So thank you so much.
Thank you so much, Dr. Shifali. An excellent presentation, and I knew beforehand that when I selected this topic, and immediately your name came to my mind. Absolute justification has been done to this topic, as you do always. Wonderful. And now we have among with us the Dr. INUSHA Panigari, Professor Unit Head Genetic Metabolic Unit PGI, who could not join at the start of the session because of some network issue. Now, ma'am has joined us. Ma'am, please give your expert opinion on this World Down Syndrome Day. Inusha, ma'am.
Yes, yes.
Yeah.
So you can hear me?
Yeah, yeah. Yes, ma'am, we can hear
Yes,
you.
ma'am.
Uh, So actually, there is a Down Syndrome Society also in Chandigarh, and we usually conduct these Down Syndrome sessions. And Dr. Gurjeet from Sector 32 usually used to organize these get-togethers, and we organize birth defects seminar in which we call these Down syndrome patients to give their own presentation, either in the form of some poetry or some cultural like dance performance. So many of you might be knowing that these Down syndrome adults are also working in Lemon Tree Hotel and also in Mercedes-Benz showrooms and manufacturing units. So if you train them, they can do repetitive tasks well, and the early stimulation is important for better outcome. And there is not much difference between mosaic down and the free trisomy 21. But if early encouragement, stimulation, and family support is there, they can do quite well. So, and they can be easily adjusted because social problems or behavioral problems are not that important in many of the Down syndrome cases, and they are usually socially well adapted. So just they need not the stigma or the alienation, but the support and inclusivity, and so they can also do good in their own way. And in competitive sports, also especially the Special Olympics, some of these patients do participate in various type of sports. And this is just to remind everyone that they are also part of the society on this day, and we should also support them. Thank you.
Thank you, ma'am, for your valuable input. And now I request our president, Dr. Kushwan Singh, sir, any comments from you?
Dr. Shifali, this was a very good presentation. And I think most of us know that Dr. Shifali is done MD Pediatrics from SGRD and later on worked with Dr. Seema also in Faridpur. So from both sides, she is connected.
Yes, sir. Thank you, sir.
Uh,
Thank you.
you're doing well in your area.
Thank you, sir.
Any comments or any queries from the participants are welcome.
Comments from Dr. Monika Sharma, ma'am, guest of honor of the day. Ma'am, your comments.
Thank you. Thank you for that. I think it was a very exhaustive session, Dr. Shifali. It was wonderful to listen to all that you said. And I remember whenever we take a session on teaching about Down syndrome to medical students, I generally tell them that if you make a list from A to Z, you can probably write one thing that can happen in a child with Down syndrome. This is the amount of problems that children with Down syndrome might be suffering. So it was a refreshing thing to listen from you about that. But one thing which I observe in the last 25 years of my experience is that the prevalence of Down syndrome in the supervised mothers is fortunately decreasing, because what we see in patients who are coming to CMC Ludhiana, like I've been seeing for the last 21 years here, that most of the gynecologists are now aware about antenatal testing, and it is quite easily accessible and available. And sadly, because now girls are also taking the decision to get married late and have children late, the number of women who are now high risk for Down syndrome is increased, which is why triple tests, quadruple tests have been done more and more frequently. And I get to hear of more and more number of women who have taken the decision to abort children where the quadruple tests have been positive, which is why the number of newborns being born within our hospital with Downs has decreased, and the number of children presenting from well supervised centers is less. But we do, yes, we do have children and families coming from remote areas where they are not aware that the child is having Down syndrome. So that is one thing that I wanted to mention. And I think one thing that we should not miss for today is that the theme of Down Syndrome Day this year is Together Against Loneliness. As doctors, we can make a list of all the problems, we can take care of all of them. In fact, we have today announced a multidisciplinary clinic in CMC Ludhiana for Down syndrome, because it's not difficult to manage the medical problems. But what we forget is when we improve the survival rates and the outcomes, what happens to these children when they grow up as adults is loneliness, because they tend to become victim of bullying. They are segregated in the society. People still have a lot of mental block against children who have special needs, and they end up not having friends or companions. And which is why the theme this year is Together Against Loneliness. We do have a very wonderful Down syndrome family group here in Ludhiana. They meet together. They have annual events. This year, I'm not aware of anything happening today, but generally they do have cultural programs, presentations. I'm myself in contact with a boy who's now beyond 30 years of age, and he's a great artist. He has exhibitions of his own. In fact, I've made purchases from his exhibitions itself. So, to say that Down syndrome child is disabled is, I think, not 100% correct, because many of them lead normal lives. The problem is in the society's views towards it. So, handicap is a social problem, not an individual problem. That is what I would like to say. Thank you, Seema.
Yes, ma'am, really true, ma'am. Actually, it the change starts from us also, ma'am, because the way we'll tell the parents, the same way they'll behave with the child, and the child will be brought up in the society. So we have to motivate them whenever they come to us and tell them to find the strengths and not the limitations. Ma'am.
I have one question for Dr. Shifali. Like these days, the girls, especially in metro, no, they go for this egg freezing and all that because they are marrying late. They are planning to have babies late. So whether
Yes.
egg freezing will have some protection or something, if like age bound, the risk can be reduced by such techniques or no?
Ma'am, for specifically, I mean, only Down syndrome, if you're asking, then there are other modalities as well. Like NIPT is a very good test that can be done during pregnancy to check about Down syndrome, or maybe amnio and CVS are quite safe. But yes, for other like overall age-related issues, जैसे ovulation will decrease, fertility will decrease later on. That for that purpose, if they are freezing eggs, then it should decrease. I mean, the incidence should decrease. But, ma'am, I would also like to mention here that it's not about the only about the age-related spindle problems, ma'am. There are research is going on
Yeah.
many things like many polymorphisms, MTHFR polymorphisms that are leading to this non-disjunction. So that those will not be related to age alone. So that way, freezing the egg will solve overall problem of fertility as well as these chromosomal disorder. But per se, for only Down syndrome, I don't know how much it will be effective.
Thank you. Thank you, Dr. Shifali.
Yes, ma'am.
Any other comments or questions you can put in the chat box or directly can switch on your camera and audio you can ask anyone of the participants
Ma'am,
side. Yeah, yeah,
hello,
please.
ma'am.
Yeah, you are audible,
Ma'am,
Dr. Shashif. Yeah.
ma'am, problem comes when the antenatal testing is normal and the patient is Down syndrome. You can't explain to the patient how it happened. Can you tell about the anti-diagnosis and sensitivity and specificity of all these tests? Particular times, the test is negative, the baby is down having Down syndrome. So it's very difficult to explain why it happened.
Yes, sir. So this is actually very common scenario that antenatally सब कुछ ठीक था और बाद में कुछ भी पता नहीं चला. The issue is the choice of tests. We should always tell them that okay, double marker is not. If a double marker is normal, it does not guarantee you that this is a normal child. It has a sensitivity of around 90 to 95% only. 5 to 10% cases will be missed. So for that, they usually offer a package of tests like you can do NIPT, which is the most accurate in these days for Down syndrome. It is though little costly as compared to Down double marker or quad screen. However, we should always inform the family that okay, this is just a screening test. It can miss 5 to 10% of the cases, and if you still wish for a more more confirmatory test, go for NIPT. And based on these, if these come out to be high risk or positive, MTP should never be offered. Always confirmation should be done by MNO or CVS. And however, these questions they get raised after the baby with Down syndrome is born. In pregnancy, no one is ready to, people are difficult to convince them that get it done.
Thank you, ma'am. Thank you.
Thank you.
Dr.
Any other?
Shafali, any particular lab for these type of tests?
So for double marker quad screen, any lab will are doing. It's commonly available. NIPT also all the genetic labs are doing. So
Same
no
as
no.
Lal Path Lab or some separate genetic labs are there?
Sir, I mean all are
Actually,
fine
multiple
only.
labs are doing tests.
Yes.
The lab credibility of the
Yes,
lab.
like Medgenome, Newberg.
Yeah, Medgenome.
So we have different labs, Unipath, Redcliffe. So different labs are there. So from
Okay.
any lab they can do the test, but they should see whether there is a quality control program for that lab also. And any good lab with good quality control, and IPT can be done.
That's why I've asked this question. Any particular lab you will recommend? We can follow, or we can follow that lab. Which one is best with your experience?
Like in PGI, we would there was an MOU with some labs. So out of them, like Medgenome,
Medgenome,
Unipath,
Life Cell and
Life
Medgenome
Cell,
are there.
they are.
Okay.
So it's because the
Okay.
whole
Okay.
genetics team is there. Yeah, you were saying something, sir. So, uh, with the permission of Inisha ma'am and Dr. Shifali, can we plan a session in future, like in coming maybe 2 to 3 months, that role of genetic in today's era? Like these days, people are ordering everything, NGS, chromosome Kralov fish, but they don't know what to order in that specific condition. So maybe we will definitely plan a session with both of you in near future. Please let us know in which month you can do. Okay. And any other question and comment from anyone? Please switch on the camera or write in the chat box. People are joining now. If there are no more questions, I think then we are done. Yeah, and thank you so much, Dr. Shifali. Very practical and very, you can say, usable on day-to-day basis for residents. The semen crease for Meghan Markle. Who was the another celebrity who had semen crease on their hand? One was Meghan Markle. Another one was you are muted, Dr. Shifali.
Ma'am, some Hollywood director. I don't
Actually, you
remember.
don't know the name. Okay, I was quite surprised to see the seam increase. Yeah, good, good. Thank you so much. Sir, कुछ और पूछना है? Or we
Then
move?
all done. It was
Yeah, yes.
it was
Thank you,
good.
Dr.
That
Shifali, Dr. Inusha, and Dr. Monika Sharma, ma'am, all the senior consultant, delegates, participant, resident, my colleagues. Thank you so much, everyone, for joining and making this session interesting and practical one. Thank you so much.
Thank you, ma'am.
okay. Thank you.
Okay.